Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape. The following presentation is part of a certified educational activity provided by Medscape Education and supported by an educational grant from AstraZeneca.
This program is presented by Medscape Education Global.
Hi, I'm Dr. Shani Paluch-Shimon. I'm the Director of Breast Oncology at the Hadassah University Hospital in Jerusalem in Israel. It's my pleasure to welcome you to this Medscape program on personalizing care for breast cancer, the precision medicine approach. Joining me on this program today are my wonderful colleagues, Dr. Nicola Fusco, Director of the Division of Pathology at the European Institute of Oncology and Associate Professor of Pathology at the University of Milan in Italy. Also joining us is Dr. Nadia Hardbeck, Director of the Breast Center in the Department of Obstetrics and Gynecology at the LMU University Hospital in Munich, Germany. Nicola and Nadia, welcome to you both.
Thank you, Shani.
Thank you for having us. Yeah.
So in today's program, we're going to provide an overview of some of the key molecular pathology testing techniques that we're currently using to personalize treatment for breast cancer in clinical practice. We'll then take a brief look beyond this and discuss how this landscape may evolve in the clinic and the care that we provide for our patients. Nicola, I'll get you to start us with an overview of what's happening from the pathologist's perspective as we come to you for more answers after we've done our initial workup of clinical staging so that we can make decisions about how to proceed with our patient care.
Thank you, Shani, for your question. Actually, the role of pathology is crucial in the multidisciplinary team because the pathology report is the cornerstone for the clinical decision making. And in particular, a report comprising all of histopathological information, including histological subtype, the presence of poor prognostic factors, the histological grading, as well as the tumor staging are essential to personalize the treatment for the patient. And indeed, our pathology report comprises several information that should be integrated for the multidisciplinary discussion and clinical decision making, comprising not only the traditional histopathological parameters, but also, given the new perspectives for breast cancer treatment, also molecular testing that is becoming more and more important, not only on the tissue, meaning biopsy or surgical specimen, but also on liquid biopsies circulating DNA. And there's a plethora of molecular alterations that can be observed in breast cancer, but at present we have a few of these alterations that are clinically actionable, and this alteration can be detected using different strategies for molecular testing for different therapeutic targets. So, Shani and Nadia, I can get you all of this information in my pathology report, but what can you do with this information?
Well, I think we utilize it greatly in the clinic, and it's wonderful to have the pathologist in the multidisciplinary team so we can discuss these issues. And we always have questions going back about assay quality, about certain findings. But I think first of all, the biomarkers we need is the ER-PR HER2, I think is our sort of basics, and Ki67 in the early stage setting as a marker for proliferation, but also then the dynamic Ki67 after the short preoperative endocrine therapy. So that is the immunohistochemistry that we need. For the HER2, I think we're going to discuss a little bit later. We're now also interested in staining beyond strong expression because we have treatments that are also satisfied with a little bit less HER2 expression on the cells, but let's talk about this later. And I think then the majority of biomarkers we need for the metastatic setting are biomarkers for the hormone receptor positive, HER2 negative field, which would be PIK3CA mutations, which was the first additional biomarker that we needed. Now we're probably going to need AKT pathway alterations, which would also include AKT and PTEN with the upcoming registration in Europe of capivasertib. We need ESR1 mutations. That's a very important marker indicating endocrine resistant, but now we also have a drug, elacestrant, the first oral SERD, that is approved just in patients with an ESR1 mutation. And then as sort of a biomarker that goes beyond just the HR positive field is BRCA status. From a therapeutic point of view, we need germline BRCA testing in all patients with hormone receptor positive and hormone receptor negative, but HER2 negative disease, because we have indication for PARP inhibitors there. And if we can sort of also include what we need in the triple negative disease there in the first line setting, we need to see whether patients are candidates for immune checkpoint inhibitors by testing for PD-L1, both in the immune cells as well as the combined positive score. So a lot of biomarkers, and some we need immediately in the metastatic setting, some we need a little bit later, but I think we couldn't do our job without you, Nicola.
I mean, it's quite incredible where we've come over the last decade, or even where we are today, with this expanding basket of biomarkers that are actionable and targetable as compared to where we were 5 years ago, even. So, we can't obviously touch on everything today, but we're going to have a look at some of these topics that have been raised. And we're going to start off by looking at the issue of HER2 testing and how that's evolved in the clinic. So, Nadia, do you want to just expand a little bit more on what you touched on now about the role of HER2? And then, Nicola, if you could then tell us about those key areas from your perspective as a pathologist.
Yeah, certainly. I mean, for I think about 20 years or so, we were just interested in HER2 as a target for anti-HER2 therapy. So HER2 3 plus immunohistochemically or 2 plus and immune in situ hybridization positive. So ish positive, that would have been what we needed, and the rest we disregarded. So we needed to train our pathologists with the advent of data that trastuzumab deruxtecan, a third generation ADC, also works if there is a little bit of HER2 expressed on the cell membrane in the HER2 low tumors, which would be 1 plus or 2 plus ish negative. And there is also some intriguing data that maybe we can even go into a little bit of what we now call HER2 zero, but there could be some ultra low if we had more sensitive assays. But I'm not the expert on that, so Nicola needs to help us out there. But just before he can explain what the challenges are, I think that the clinical data is quite intriguing with the presentation of the TDXD data in the Destiny Breast 04 at ASCO 22, I think, where we had data that TDXD improved survival compared to standard of care monotherapy in the hormone receptor positive setting. That was the primary endpoint, but also in the hormone receptor negative HER2 low setting. And I think with the survival advantage of median 6 months, we have seen an updated data set last year at ESMO 2023 by Dr. Modi, and the data held up very beautifully. So this is a standard of care now in the second line setting in the hormone receptor positive, and the second or third line setting in the triple negative. So we need that HER2 low expression to be reliable. And from a clinical point of view, we don't care when it happened, whether it's the primary tumor or recent metastasis. And my understanding, Nicola, but maybe you can correct me there, is that if we have a sufficient number of biopsies or samples, there is always one that is HER2 low because it's sort of a very heterogeneous factor.
Yes, Nadia, you are totally right. Her two keyword is heterogeneity. And actually, the guidelines for HER2 testing, in view of the DB04 study, actually didn't change despite the ASCO CAP 2023 updated guidelines, as well as the 2023 ESMO recommendation for HER2 testing. And HER2 is an immunohistochemistry-based test in which we have a spectrum of expression, a spectrum of positivity based on the intensity of the staining on the membrane of the cell, and also on the continuity, so the pattern of staining on the surface of the cells, as well as the percentage of positive tumor cells. And indeed, we have the three-tile scoring system in which we have a score 0, 1 plus, 2 plus, or 3 plus. So until the DB04 study, the HER2 positivity was dichotomous, meaning positive if it was 3 plus or 2 plus ish positive, or negative all other cases. Now with HER2 low, meaning score 1 plus or 2 plus without gene amplification and in situ hybridization, this subset of patients that actually represent the majority of patients with breast cancers have this new therapeutic possibility. And Nadia, you mentioned also the ultra low, and actually this is a real issue, meaning a challenge for pathologists, because to ultra low are inside of the score 0 box, and meaning that this score 0 comprise subset of patients with faint positivity in less than 10% of tumor cells. So the issue now is to discriminate between the score 0 and score 1 plus. And the issue is related to the fact that now we have an indication that back a couple of years ago, we didn't. So for testing, the present data suggest for retrospective samples to retest HER2 in case of score 0, given in view of the new therapeutic indication. And the heterogeneity of HER2 testing is also reflected by the heterogeneity of the possible technological platform that can be present in different pathology laboratories.
It's interesting because there was a paper presented at ASCO, and they looked at repeated biopsy testing and how HER2 status changed over time. And so I wonder if we'll just get to a point where we give anybody or everybody trastuzumab because of that heterogeneity and differences in sampling.
Yes, this is true, Shani. And there are several considerations about that, and these are mostly related to the heterogeneity of HER2.
All right, so I think we'll move on now to discuss a little bit about germline BRCA testing, which has become, a very important issue with the expanding therapeutic implications of the testing.
Exactly, and Shani, you are the authority on breast cancer genetics here. So what are the current recommendations for germline genetic testing for BRCA?
So if you look at the ESMO early breast cancer and as well as advanced breast cancer guidelines, the guideline is that anybody who's eligible for a PARP inhibitor should be tested for germline BRCA mutation. And this is obviously deviating away from standard genetic testing guidelines and recommendations. So I would differentiate between national recommendations about testing according to risk, family history, tumor subtype, for example, triple negative breast cancers up to age 60, as opposed to patients who are already diagnosed with breast cancer and according to their stage of disease could be eligible for a PARP inhibitor. So these are two distinct groups when we think about who we're going to test.
So, Shani, do you think that we test enough patients? I always have the feeling that we think about it in the triple negative group, but for the hormone receptor positive, I don't think we connect so immediately the BRCA testing and the PARP inhibitor there.
So it's interesting because I also have the same impression, and I think in the patients with advanced breast cancer, we should be offering it to most of our patients, including the hormone receptor positive patients. And I always give the example, the chances of finding a BRCA mutation in an unselected population will be between 5 to 10%. But if we think about non-small cell lung cancer and ALK alterations, so they're present in approximately 5%, and everybody tests for that because it's a druggable, target. And so we need to remember that this is a druggable target. And I agree that this should really be part of the initial workup and biomarker profiling very early on in the disease in the advanced breast cancer setting.
So maybe Nicola is a good person to answer that as well. So is the germline testing, we could also test in somatic if we have a molecular tumor board, you will give us that information anyways. Is that valid, or is it more that we should look what the clinical implication is and the indication is for germline?
That's a great point, Nadia. As also Shani was saying, the frequency of BRCA alterations, even in low risk individuals, meaning patients young or without any family history with hormone receptor positive tumors, we can find some BRCA mutation up to 10% of cases. So the point is how to test. In my opinion, we have to rely on the data from clinical trials and the guidelines. So at present, the somatic testing for BRCA should be integrated with the germline testing, but at present we have no data for and guidelines for considering this test as an alternative to the germline testing. So the collaboration between oncologists, geneticists, and pathologists for BRCA testing is crucial.
But maybe, Shani, I mean, we do have this small study from Dr. Tang, the TB-CRC 48 study, where they showed that in addition to the germline BRCA mutation carriers was also patients with a somatic mutation as well as those with a germline PALB2 mutation that actually benefited from a PARP inhibitor. In our German guidelines, we include those patients as potential candidates because I think there will never be a prospective trial randomizing that question. Would you agree with that? That if you don't have the germline BRCA information, or if you have it and it's wild type, but there's a PALB2 mutation, that we should treat those patients as well?
I fully agree with you, and I agree that we're not likely to have another study looking at this. And it's an important point to remember. So people sometimes forget, firstly, about somatic BRCA mutations independent of germline, and the issue of PALB2 germline mutations is very important. And I think what's another interesting point, and it comes back to what you asked me about hormone positive patients being tested, is that in that study, a significant proportion of the patients with the germline PALB2 mutation had hormone receptor positive breast cancer. So it's sort of just brings home that point that we really need to take the bigger picture into consideration and not be stuck in misconceptions about hormone positive breast cancer and its association with germline pathogenic variants. I wanted to ask you, Nadia, if we're talking about hormone receptor positive patients and BRCA germline mutations, there's been some discussion in the literature and at conferences suggesting that maybe CDK4/6 inhibitors are possibly less effective in patients with a germline BRCA mutation. Would you like to comment on that?
Yeah, I think that's an important question because it's always been raised, and it's about sequencing and maybe to choose one drug over the other, which affects the metastatic setting as well as the early breast cancer setting. Now, I think the data is mostly retrospective, and there's some also preclinical data showing that the wild type BRCA1 inhibits the estrogen receptor alpha, or that BRCA per se is involved in cell cycle arrest. So it makes sense if there's a mutation that drugs targeting the same pathway may not be as effective. And we see poorer outcome in patients with a BRCA mutation and receiving a CDK4/6 inhibitor in the metastatic setting. And that was also tested in multivariate analyses. But I think if you look at the articles carefully, the authors themselves also write down some caveats. I mean, these treatment decisions were done by the clinicians. So if you look at the BRCA mutation carriers, they're mostly younger women. They're mostly have more pre-treatment with chemo, but also with endocrine options. So I think the verdict is still out there. And if they have a slightly lower response rate to the CDK4/6 inhibitors, they may still benefit on an individual basis. So I would put my indication in those BRCA mutation carriers for CDK4/6 inhibitors as I would do otherwise. But I would maybe in the early breast cancer setting in a setting where I could do that, give olaparib as well as abemaciclib to be precise, but sequence them. And in the metastatic setting, I think they should receive a CDK4/6 inhibitor, but they should also receive a PARP inhibitor once the chemotherapy comes into play. So yes, there's data out there, but I don't think the data is strong enough to withhold CDK4/6 inhibitors from BRCA mutation carriers. But I'm interested whether you agree or not.
I fully agree with you, and I think that there's pretty good consensus about that. So that even if there is slightly less efficacy, the CDK4/6 inhibitor is still very beneficial, and in fact, that's supported by both the ESMO and the ABC guidelines. So I think that's relatively accepted, and I fully agree with your comments on this issue. If we move along now, what about a little bit about the PIK3CA AKT PTEN access? What are our thoughts about it? Where is this going? We've got all these new drugs. We have the capivasertib, which is an anti-AKT, as well as alpelisib, everolimus as well, coming into it. So what status are we going to be looking at? And what are your thoughts, Nadia, about this pathway and how we're going to best target this pathway?
Yeah, I think it's been an important pathway. You mentioned the drugs that we already have. We're expecting capivasertib to be approved in Europe. It already has an FDA approval for AKT pathway alterated tumors, and I think Nicola can give us a little bit later more details about the exact testing. But from my understanding, I think PIK3CA mutations are still the most frequent alterations in that pathway. So we're going to use those. Then we have AKT and PTEN and need to test that in addition. And then we will have the choice for PIK3CA mutations, capivasertib or alpelisib, which then we have to look at the different toxicity profiles. We don't have much experience with capivasertib. We had it in the registration trial, and my take was that there were some pathway based toxicities, but they were less severe than with a PI3 kinase inhibitor. We have no idea whether sequencing some of these agents may also be an option. I think for that we will probably never have a prospectively randomized trial, but we can look at some real world data, in particular with everolimus, which works independent of pathway alterations. And it's an old drug, but it's still a good drug. We've had patients being stable for more than 2 years. I think it's good that we have all these options because there are distinct toxicities, and everolimus has ILD but doesn't affect the sugar so much. So I think it's good that we have all these options, and we have to make a decision on an individual patient basis. But I'm still confused with the pathway alterations, because in the paper, if you look at the Capitello trial, it's not very clear what they used. And in the US, they have a different way of calling it a companion diagnostic versus what we do in Europe. So Nicola, do you have any idea how that's going to end up? And can you give us some recommendation? When I tell you I want to check for AKT pathway alteration, will your answer be the same as that of my pathologist?
Nadia, this is a great question. Actually, PI3K was the first molecular target after HER2 in breast cancer, and with them to be achieved due to this new molecular testing in breast cancer that was not available before by real-time PCR or by next-generation sequencing, that now we have the necessity of providing molecular information about the entire pathway, including PTEN and AKT, of course. Actually, the best testing strategy is still a matter of controversy, particularly for PTEN. We have immunohistochemistry, assay for PTEN expression, and also NGS panels can cover some hotspot regions of PTEN. And the issue is not only related for PI3K and the AKT pathway, is not only related to the type of testing strategy, meaning NGS versus real-time PCR, but also is related to the type of biomaterial to be tested, because PI3K can be detected on primary tumors, on metastasis, but also on circulating tumor DNA, ctDNA, on liquid biopsies. And actually, with PI3K, we are on the safe side, meaning that we don't have that much temporal heterogeneity. So it's an alteration that is a founder genetic event for breast cancer tumorigenesis, so can be detected in the primary tumors, even in the biopsy, pre-surgical biopsy or pre-neoadjuvant therapy biopsy, and also in the metastatic setting. So for the guidelines at present, we have the possibility of choosing an assay that has the reference range, regardless of NGS or real-time PCR, that has a reference range covering at least the hotspot regions of PI3K, and we can test both tumor tissue and liquid biopsy.
And are you satisfied with the correlation between NGS with liquid biopsy as opposed to tissue?
Yes, Shani. Actually, the correlation between PI3K testing on liquid biopsy and tissue is it's quite high. Of course, it's not 100%. And in this case, if the clinician, the oncologist, has the necessity of having deeper information, we can test as frontline testing liquid biopsy, and in case of negativity, go back to the tissue and test the tissue.
So, in hormone receptor positive breast cancer, we've got this plethora of growing options. And the other big issue is the ESR1 mutation in terms of resistance. And this is in light of what Nadia mentioned earlier, is that we now have an oral SERD that's available. And there's been some other data about early switching of treatments based on ESR mutation coming through. Nadia, would you like to comment on that? And Nicola, if you could share your thoughts as well about what the best way to be testing for that, and how often should we be testing?
Actually, ESR1 mutation is a completely different story from PI3K. While PI3K can be detected in the primary tumor and also in the metastatic site, for ESR1, only a very small subset of patients display this alteration in the primary tumor. So the gold standard testing strategy is on liquid biopsy. So in this case, ESR1 testing can be performed by NGS, of course, but also on digital droplet PCR, according to the clinical trials that have led to this new approval. In the real world scenario, we can say that after progression to endocrine treatment, up to 20% of patients can show this type of alteration, ESR1 alteration, but we still need more real world data to achieve a complete understanding on the exact frequency of this alteration based on the clinical scenario. And Nadia, what do you think? These types of alteration can be led by specific treatment, or these types of alteration can be also related to other clinical pathological and molecular factors of the patients?
Yeah, I mean, it's an interesting mutation. We've learned that it mostly comes up with patients have been pre-treated with an AI in the adjuvant setting, then we find it in the metastatic setting. And until the approval of elacestrant, it didn't play a big role, because in the first line setting, we don't give monotherapy AI. So we really didn't need to know whether there was this kind of resistant. But now with the advent of elacestrant as a targeted therapy, it's the first all SERD to be approved, and the approval is linked to detection of ESR1 mutations, because in the Emerald trial, the registration trial, what we saw was that the efficacy was there in the whole population, but it was more effective in the ESR1 mutated tumors. And I think the data, particularly in those tumors that had responded for a year or so on a previous CDK4/6 inhibitor, we see in the control arm very limited response of about 2 months, and in the elacestrant arm we see a progression-free survival of more than 8 months in median. So I think there's a difference there, and in particular it works well in those tumors that have already responded to a prior line of endocrine therapy. So I think with that, ESR1 mutation is important. We're going to have to measure it once we think about sequencing in the hormone receptor positive space. And the other intriguing data is the data of the PADA-1 study, where our French colleagues looked at whether there was appearance of ESR1 mutation in sequential blood draws under AI based therapy together with a CDK4/6 inhibitor. And then they saw that the patients benefited from an early switch on the appearance of ESR1 mutations instead of waiting for tumor progression on CT scans. Whether that is a strategy that we're going to incorporate in the future, I'm not so sure. I personally think we need to see overall survival data for those patients, whether the early switch actually helps them to survive longer or whether it's just a cosmesis with regard to PFS. So I'm cautious. You may call me conservative. I don't think we have ctDNA measurements incorporated in our daily management routine yet, but it could well be in the future if we have more and a broader database to sort of support that.
Yeah, I think there's a Serena 6 study going on looking at this kind of strategy, and I think that will be very informative and very helpful moving forward. So we have all this new information, and where there's more and more use of next generation sequencing. Now, originally, when this testing was starting to be used, and it was new to most of us, what was established were these molecular tumor boards. And the question is whether they still need to continue to take place independently, or is this already going to be integrated into our routine tumor board or clinical meetings? Nadia, what are your thoughts?
So maybe I think what we need clinically is just a few biomarkers. As I said earlier, we need them early. So probably a small panel upon first sight of metastasis would be enough for our MDT discussions. But I think the molecular tumor boards at a later stage are also important because they test for many more alterations. And I think the idea of the complete NGS panel is that we get ideas whether there is driver mutations that have treatments associated to them that we don't necessarily think about in breast cancer. And we haven't talked about these less frequent alterations that could be therapeutically relevant, like, for example, NTRK fusion proteins and HER2 mutations and all that kind of stuff. So I think molecular tumor boards to look at a broader spectrum of tumor alterations is still something that we need, and we need to feed that information, which comes from a very multidisciplinary panel of methodologic, very versed colleagues and clinicians, and also some AI support to tell us where there is any data in the world sort of helping us with that particular alteration. And we need to feed that back into our routine multidisciplinary discussions, because only there we can decide what's appropriate for the individual patient. So I think we need both, but maybe in the future, and maybe Nicola has some idea, when I have a patient with first metastasis, I need a certain spectrum of biomarkers, and maybe we should have these breast specific panels early on and not very late in the disease.
I agree with you, Nadia. At present, we need both for an integration of the information. But as long as we test these selected biomarkers, this alteration can be discussed in the conventional multidisciplinary team. But when we need, in particular in a metastatic setting, comprehensive genome profiling, or maybe for BRCA and the homologous recombination deficiency pathway, in these cases, of course, with comprehensive genome profiling, the discussion in the metastatic setting can be integrated with that of the molecular tumor board.
So I think, we're seeing how treatment of breast cancer has really evolved in these last years, and we really are moving more and more forward towards precision medicine. And we've touched on some of the key important alterations in our meeting today. There are other ones, but these are the ones that are really topical at the moment, where clinical practice has changed quite dynamically over these past years. So what I'd like to do is thank you for your time, both Nadia and Nicola, for a great discussion.
Thank you, Shani. It was a pleasure being with you.
Thank you. Always a pleasure.
And thank you to the audience for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. Have a great day. Thank you.
This program was presented by Medscape Education Global.